Welcome to this Responding to Minor Ailments lecture where we're looking at eye and ear conditions. In part 1 we will look at eye conditions in particular. The aims and objectives of this lecture are to look at common eye and ear conditions presenting in community pharmacy, learn how to manage each condition with appropriate over-the-counter products, also giving lifestyle and non-pharmacological advice, and how to identify warning signs that make it necessary to refer a patient to another healthcare provider. Couple of bits of terminology for your information. In medicine, the speciality treating eyes is known as ophthalmology, and the speciality treating ears is ear, nose and throat, commonly known as ENT in the UK. So first of all, let's look at some anatomy of the eye. Hopefully you're familiar with this already, but just go over some of the main structures. Most symptoms that will present in the community pharmacy will affect the cornea and conjunctival areas and the eyelid. So if we have a look on the left-hand diagram, you can see where the conjunctiva is and the cornea. The conjunctiva is the layer that kind of covers and works up to the cornea, and the cornea is the layer that covers the iris and the anterior chamber of the eye. And on the right you can see the eyelid and a front-on view of the sclera, which is the white part of the eye, and the main diagram there gives you some more detail of the interior of the eye. So have a look at that just to familiarise yourself with the structures in the eye. Quite a few different disorders can affect the eye. Some of the main ones are listed here. So obviously you can get infections such as bacterial conjunctivitis. Some of you may have experienced allergies caused by things like hay fever or pets. You can also get dry eye where the tear production is malfunctioning. You can get stye, which is like having a spot on your eyelid, cataracts, blepharitis, macular degeneration, and also subconjunctival hemorrhage, which we'll come on to in next slides. So here's a little test for you. If you're familiar with any eye conditions already, take a look at these slides, think about what I've mentioned already, and see if you can identify any of these eye conditions on this slide. And here are the answers. So top left, we've got viral conjunctivitis, so inflammation of the conjunctiva caused by a viral infection. Allergic conjunctivitis is next. You can see they actually look quite similar. Subconjunctival hemorrhage, where you've got bleeding on the surface of the sclera of the eye. Below that we've got a stye. You can see there that's kind of looks like a small abscess or spot developing on the eyelid margin. Middle bottom there we've got a cataract with the opacity of the lens visible, and then the last one bottom left is bacterial conjunctivitis with the characteristic yellowy green discharge and inflammation of the eye and eyelid. So looking at conjunctivitis, this is inflammation of the conjunctiva. It can become inflamed due to several different reasons, most common ones being bacterial infection, a viral infection, or an allergy. So as a community pharmacist, you need to be aware of these and how we differentiate between these three causes of conjunctivitis. So here we've got a table which gives the common symptoms of each type of cause of conjunctivitis. You'll see with bacterial conjunctivitis it tends to be self-limiting and of relatively short duration. With viral conjunctivitis, it often will go on for 1 or 2 weeks. And then with allergic conjunctivitis, duration is variable depending on the cause of the allergy. So if it's hay fever, it's likely to be for a few weeks during the spring-summer period. But if it's a pet allergy, it might be something that is continuous on exposure to the allergy-causing pet. Spend some time looking over that table and get familiar with the differences in how we identify the different types of bacterial, viral or allergic conjunctivitis. So due to the several different causes of conjunctivitis, we have to make what's called a differential diagnosis. So a differential diagnosis is a list of possible conditions that could be causing the symptoms and signs that somebody is having. Different conditions can produce the same symptoms, so it can be quite difficult to tell the difference just on examination. So once you've listed your possible diagnoses, you would then perhaps run some tests, or if a patient's in hospital, you'd run tests on the patient to confirm or exclude each differential diagnosis. So for conjunctivitis, we've mentioned allergic rhinitis. We've mentioned allergy, and so if somebody has conjunctivitis and also has allergic rhinitis, that could either contribute to the conjunctivitis or it could help you make a differential diagnosis that the conjunctivitis is caused by an allergy. Patient could have another viral infection. Apparent conjunctivitis could actually be the irritation caused by dry eye. It could be a secondary infection of the eye caused by something else, or it could be a symptom. If a patient's got cold and flu, you can sometimes get eye involvement that looks like conjunctivitis. So looking specifically at bacterial conjunctivitis, and this is where we've got inflammation of the conjunctiva along with the sticky eyes and the yellowy green discharge. Most commonly offered over the counter in pharmacies would be antibiotic eye drops, specifically chloramphenicol. It's licensed to be sold for 5 days treatment only, so if symptoms persist, the patient should then be referred to a doctor. In terms of the regimen, 1 to 2 drops should be instilled into the affected eye every 2 hours for the first 2 days, and then reduce the frequency to 4 times a day for the remaining 3 days. And the drops for chloramphenicol have to be stored in the fridge. So that can be tricky for some people. It's important to check whether it's possible for the patient to store it in the fridge. If they're not able to store in the fridge, it may be better to give them the ointment instead of chloramphenicol, and that's applied 4 times a day for 5 days. However, that can affect vision because ointments tend to be greasy. So if somebody's driving a lot, for instance, then the ointment may not be so suitable. Important to remember that chloramphenicol is only licensed for children aged 2 years and above, and when you are doing consultation for chloramphenicol, the patient or carer must describe the specific symptoms. I will upload the guidance on that to Blackboard so you can refer to that, but that guidance is available on the GPHC and RPS websites. Other options for bacterial conjunctivitis, so another eye drop for somebody that can't use the ointment and can't store chloramphenicol in the fridge could be propamidine drops, which brand is Broline, or it comes as an ointment. Golden Eye, so the picture of Golden Eye there is actually a chloramphenicol ointment, but you can also get drops that contain propamidine, having trouble with that one. Remember that drops should not be used in patients, or treatments such as drops and ointment shouldn't be used in patients with contact lenses, or they should not use their contact lenses whilst they're treating an eye infection. And also chloramphenicol should be avoided in patients with blood dyscrasias or any medicines or conditions that are affecting their bone marrow, because chloramphenicol can cause bone marrow suppression, and even the small doses used in eye drops or eye ointment can affect those patients. Looking at treatment for allergic conjunctivitis, if it's just the eyes that are affected, then it may be appropriate just to use some suitable eye drops. So over the counter, you can supply the topical mast cell stabilizer sodium chromoglycate. This will help reduce the release of histamine from mast cells in the eye and reduce symptoms. They can be used in patients of 12 years and over, up to 4 times a day, 1 to 2 drops. You could use an antihistamine eye drop such as otrivine antihistin, which contains antazoline and xylometazoline. They can sting quite a few patients, so if they don't tolerate it, you may have to use something else. The xylometazoline is a sympathomimetic, which helps to dry up the secretions in the eye. That can only be used in patients above 5 years of age, again for short-term use. You should avoid these treatments in patients that are taking monoamine oxidase inhibitors and who have glaucoma, which we'll come on to in a moment. And then viral conjunctivitis. There's no specific treatment for viral conjunctivitis, so it's a matter of recommending supportive therapies. So patients may find that hot or cold compresses can help relieve the discomfort. So that would be something like a face flannel soaked in hot or cold water and then applied to the eyes. Eye drops or ointments that treat specific symptoms could be useful. So perhaps if somebody is experiencing grittiness or dryness, they could use a lubricating eye drop, which may help with that. Decongestants, so a decongestant drop can help reduce the surface swelling. So something like the otrivine white eye. Antihistamines can help reduce the itching, so a drop or systemic antihistamines. Vasoconstrictors will also help to whiten the eye. And so we use similar treatment options to the allergic conjunctivitis. Some non-pharmacological and lifestyle tips to help patients manage the symptoms when they have an eye infection, particularly something like viral conjunctivitis or bacterial conjunctivitis, which are both very contagious. Patients should wash their hands regularly, particularly if they are touching their eyes. Bathe their eyes with warm water to remove any discharge, particularly in bacterial conjunctivitis. When they are cleaning the eye, they should wipe from the inside out, so from the bridge of the nose to the outer corner, and should use clean gauze or cotton wool each time to reduce the risk of spreading the infection to either the other eye or continuing the infection by reinfecting, and protecting the eyes from wind and sun by wearing sunglasses. And if somebody's getting allergic conjunctivitis and pollen as a trigger, then sunglasses can help reduce the exposure to pollen when they're outdoors. It's really important that people with infectious conjunctivitis do not share towels, face cloths or pillows, because obviously that can help spread the infection. It's really important to try not to rub your eyes because that can make it worse. And patients should not wear contact lenses until the infection or the problem has cleared up. So looking at other eye conditions, some of these can be treated over the counter and others are for your information about conditions that patients should be seeing either an ophthalmologist or an optometrist about. So glaucoma, you've probably heard of this. It's a group of eye diseases that can cause vision loss and blindness because the increased intraocular pressure in the anterior chamber of the eye can put pressure on the nerve at the back of the eye, that is the optic nerve, and by damaging it can cause decrease in vision or blindness. So obviously glaucoma should be detected early if possible and treated. So glaucoma tends to have very few symptoms and they come on quite slowly, but because of the increased intraocular pressure, some people will complain of pain. So if somebody is complaining of a painful eye, they should be referred to an optometrist or to their GP for further investigation. Episcleritis and scleritis. So as mentioned with the anatomy of the eye, the sclera is the white part of the eye and the episclera is the layer above it. And so inflammation of this area can cause patches of redness and pain. It's sometimes linked to rheumatoid arthritis. It can look similar to the image on that slide there. This would require referral. Chlamydia, the sexually transmitted disease, it can be spread to the eyes and cause some issues there. It's also a sexually transmitted disease and occurs most commonly in sexually active young adults, and women are more susceptible than men. It's usually transmitted through hand-to-eye spread of infected genital secretions. The incubation period is about 1 to 2 weeks. It can cause irritation, pain, swelling, and will often be associated with a genital infection, although you may be aware that chlamydia in the genital infection has no symptoms and can go undetected. You can see there that image, that looks like quite a severe case. It does look very unpleasant and uncomfortable as well. Obviously that would require referral for appropriate antibiotic treatment. And then we come to corneal ulcer, also known as keratitis. So this picture here, this kind of diagram, shows a white spot just over the pupil. And that's what a corneal ulcer can look like. It forms smallish white craters on the cornea, and also inflammation, pain, and a watery eye. So something like that would also require referral to the appropriate professional. Dry eyes caused by tear deficiency, and this can cause discomfort. It can be caused by some medications, which can be caused by some medications such as some antihistamines, anticholinergics, things like that. Also central heating, air conditioning, where the air tends to be very dry, the use of contact lenses, spending too long at a computer screen, patients with thyroid problems, women post-menopause may find that they get dry eye. It tends to be bilateral in symptoms, so soreness, irritation, grittiness, and can be aggravated by dry air, such as in central heating or aircon, dust, wind, and smoke. So cigarette smoke or other types of smoke. You can see in the image here a diagrammatic representation of the symptoms. And then we come on to subconjunctival hemorrhage. This image here is of quite a severe case. It could just be a small spot of hemorrhage, or as you can see here, almost complete hemorrhage across the whole of the sclera, which looks quite alarming. So this is caused by burst blood vessels, is usually self-limiting, can often be associated, however unlikely it seems, with sneezing or when blowing your nose. So that would be caused a spontaneous hemorrhage, and some of you may have experienced that or know somebody who has. It can be very alarming to the patient because it looks pretty awful, but if there are no other symptoms, then usually it's just a hemorrhage and patients don't need to worry. However, if they're on blood thinning medications such as warfarin or aspirin or dabigatran, anything like that, then the patient should be referred because their drug treatment may need to be reviewed. But if they don't have any precipitating factors, then it's a harmless occurrence and symptoms will usually fade over a few weeks as the blood is slowly cleared from the tissue. Macular degeneration, so this is something that would be diagnosed by an ophthalmologist, so this is for information rather than something that you would be involved in offering treatment for, but you may well dispense prescriptions for the drugs used to treat macular degeneration. So this is a disorder of the macula, which is the part of the retina responsible for central vision, colour vision and fine detail. It's also referred to as age-related macular degeneration, or AMD, because it does tend to develop with age. It develops when the macula is unable to function as effectively as it used to. There are two main types, dry AMD and wet AMD. So you can do some further reading about that if you want. There's plenty of information available in the further reading or on reputable sites online. And then we have cataracts. So this is where the lens of the eye becomes progressively more opaque, causing blurred or misty vision and eventually blindness if left untreated. It tends to be related to age, but also injury to the eye, certain types of surgery, diabetes, and treatment with long-term steroids can all increase the risk of glaucoma. Long-term inhaled steroids can contribute if somebody's technique is poor and they're actually getting the in steroid inhalant going into the eyes, also long-term treatment with tablets. Symptoms: initially bright lights can be dazzling. Patients may find they have discomfort when moving from shade into light, and their vision is not improved if they put their glasses on or insert contact lenses. Initially, patients may find that a tinted spectacle or a new prescription may help, but eventually patients will get to the point where they need surgery, which obviously would be undertaken in hospital. So let's look at some treatment options for dry eyes. This is treated with moisturising drops, often known as artificial tears. These drops could contain any number of compounds. We commonly use hypomellose quite often, although that's not always very effective. Other products may contain polyvinyl alcohol, carmellose, acetylcysteine. They may have a paraffin base, particularly the more ointment-like drops, or they may contain carbomer. And different types of product will be suitable for different types of dry eye. If a patient does end up needing to be referred because over-the-counter treatment is not effective, then an ophthalmologist will be able to determine what the tear imbalance is, whether it's the aqueous or the lipid phase of the tear which is out of balance, and then treat it accordingly. Macular degeneration has no cure, but some patients may be recommended to take some supplements that have some evidence to show that they can help support eye health. So there are some high dose vitamins and mineral supplements. Some name products include Preservation Original Tablets, VitEyes and MacuShield. So do have a look at the information about those online, and have a look at the evidence and see what you think about how strong the evidence for those is. So moving on to eyelid problems specifically, these are things that you certainly may see people come in with, and there are some things that you can help with. So blepharitis, this is a chronic inflammation of the margins of the eyelid, so the edges around the area where the eyelash grows from. And this can affect both eyes, or tend to affect both eyes at the same time. As you can see in this picture, the eyelids become red, they can be scaly and flaky, and eyelashes may fall out. This is often caused by a staphylococcal infection, or it could be caused by allergic dermatitis or seborrheic blepharitis, which is often associated with oily skin, and patients may also have dandruff of the scalp and the eyebrows. We'll come on to treatments in a moment, but it's important with blepharitis that if a patient doesn't respond to treatment, you should refer the patient to the doctor, because prolonged problems with blepharitis can lead to ulceration. And also, if eyelashes are starting to regrow at a bad angle, that patient should be referred, because those eyelashes could cause conjunctivitis and corneal damage. As you can see in the image below, a stye tends to look like a little pimple or spot on the edge of the eyelid, although they can develop further up the eyelid, top or bottom, and it can be quite painful and irritating. It's basically usually caused by a bacterial infection of the hair follicle, so they do often look like they're growing at the base of an eyelash. They do cause irritation, soreness and pain, and they can start with swelling of a larger part of the eyelid, which then will reduce into the pimple-like head that you can see in this picture. With blepharitis, usually first-line treatment will be regular eye washing of the eyelids, and often people are recommended to use baby shampoo, 1 part in 10 parts of water, and something like a cotton bud or some kind of swab to gently wash away and kind of move away the congestion you can see there from the discharge. A warm compress or a warm wet flannel may help loosen the crusting that occurs. Blepharitis may also cause dry eye, which would need to be treated separately. Some patients may require antibiotics. As mentioned before, it's often caused by Staphylococcus, so some antibiotics will help to clear that infection up. Patients suffering from blepharitis should be advised not to wear eye makeup. And there are some over-the-counter products available which help with cleaning the eye and easing the symptoms, and kind of regular maintenance to help reduce the symptoms or prevent them from recurring. With the stye, you can see another picture here of a stye. We can see the inflammation of the eyelid around the head of the stye. So again, applying a warm compress for about 5 to 10 minutes, and if that's repeated 3 or 4 times daily, that can help to drain the stye away and help it resolve. But the compress should not be very hot. The skin and the eye is sensitive, so you don't want to be applying very hot things. And advise patients to not attempt to puncture an external stye, much as some people may squeeze their spots, but it's not advised to do that because it actually can get infected and become worse. It's the same with a stye. Patients should not attempt to puncture them or squeeze them, should let them resolve naturally. So we've talked in previous slides about eye drops, and it's important that you know how to apply eye drops safely and properly, and so you can advise your patients appropriately. So I'm not going to go through all of this on here. Obviously you can read this through yourself, but some of the key points are that people should always wash their hands first before handling the eye drops and starting to apply them. Patients should avoid touching the dropper to any part of the eye, so that the dropper doesn't get contaminated with the causative organism if it's an infected eye. And the eye can actually only contain 1 eye drop. If you apply more than 1 drop at a time, the second will generally just overflow and overflow down the face. So unless the first drop didn't go into the eye properly, patients should be encouraged to just use 1 eye drop. And if a patient's using eye drops and an ointment, they should add the drop first and wait about 5 or 10 minutes before adding the product or any other eye drops. So some patients have to use more than 1 eye drop regularly. They should wait 5 to 10 minutes in between the drops, because the eye can only contain 1 drop. If you apply different products one after the other too quickly, the subsequent ones will just wash the first ones out. Here's a video on how to apply eye drops. So this is quite a nice little summary of how to give drops. So with eye infections, there are other points to consider when you're talking to your patient. So questions to ask and things to take account of when you're choosing what to supply or recommend to your patient. So contact lens wearers, some eye drops will affect contact lenses. So always check the package insert and see whether lenses can be worn whilst those drops are being used. This picture here of kind of cosmetic contact lenses, just a reminder that this applies to not only contact lenses to correct vision, but also cosmetic contact lenses that people may apply to change their eye colour or to change the appearance of their eye. They need to take all the same precautions with those as they would do with vision correcting lenses. Some systemic drugs such as rifampicin and sulfasalazine can actually colour the secretions of the eye, and they can stain contact lenses. So patients should be advised to not wear their lenses whilst taking that medication. Contact lenses may be more susceptible to certain eye infections, so it's really important they have very good hygiene. They clean their lenses regularly and properly according to the manufacturer or optometrist's instructions, and they should never skimp on lens cleaning. And always check product suitability, as patients often ask about lubricating eye drops for use with lenses. Check the information of each product to make sure that it's suitable with the type of lens that they wear. Going on to pregnant, breastfeeding women, you need to take special consideration to check whether eye drops or eye treatments are suitable for patients that may be pregnant or breastfeeding. Other special patient groups. Also think about whether a patient will tolerate a preservative or not. Preservatives in eye drops can be irritant, so if patients find that they get stinging, it may be worth trying a preservative-free product. The preservatives in eye drops will discourage the growth of bacteria once the bottle has been opened. So quite often preservative-free eye drops will actually be in single dose droppers, so small plastic droppers that are used and then thrown away. If somebody is going to be applying, for instance, an artificial artificial tear more than 4 times a day, then it's better for them to use a preservative-free product because the more you use a preservative eye drop, the more likely you are to become sensitive to it. And Lastly, other considerations when you're counselling a patient. Most eye drops have a 28-day expiry after opening, so patients should be advised to throw away the bottle when 28 days is up, and also they need to remember to write the date of opening on the bottle so they know when that 28 days has come. Some products can be used longer than that, so always check the product information. And if a patient is using an eye drop for an eye infection, they may be advised to throw the bottle away after 7 days, start a new one, particularly in hospital. That tends to be done. That's to reduce the risk of contamination of the bottle and reinfection of the eye. So, summary of the questions that you should be asking when a patient comes in with an eye condition. So you'll be familiar with these questions here. So who is it for? What are the symptoms? How long have they had the symptoms? Have they tried anything to relieve the symptoms yet? And are they on any other medication, or do they have any other medical conditions? So you should be familiar with those questions. And then we're looking for questions such as who's it for? Not all products for eyes are licensed for use in young children below 2. Remember that chloramphenicol cannot be used in patients that are younger than 2. You also need to think about the product you recommend. Is it going to be feasible to put an eye drop in the eye of a baby, or an ointment is one better than the other? Does a child or an adult have a preference for what kind of product they use? What are the symptoms? So thinking about referral symptoms, which we'll come on to, but things like pain. Do they have a discharge in the eye? Is their vision blurred? Is it affecting one or both eyes? And what other symptoms do they have? How long have they had the symptoms? Is it more than 7 days? Is it more than 2 weeks? If it's more than 2 weeks, remember you may need to do an immediate referral. Have they tried anything yet? So that could be yes, no, or they've tried something and it's failed, so they're looking for further treatment. And are they on any other medications? So remember, anticholinergics can dry up secretions, so may cause dry eyes. Have they been on some antibiotics already? Do they take over-the-counter, herbal, prescription-only medicines, supplements, patches, checking all of those other medicines. So, referral or red flag symptoms. Pain in the eye should be a referral, immediate referral. Remember, some symptoms like conjunctivitis or dry eye may be itchiness, grittiness and soreness of the surface, but if somebody has got pain in the eye, or it's painful to move the eye, they should seek medical advice. Visual disturbance, so blurring or a mark in the field of vision, requires referral. If the pupils look unusual, so if they're different sizes, or they look torn, or they're sluggish, non-reactive to light. If there's a treatment failure, so patients had some treatment for 7 days or up to 7 days and it's not working, then you should refer them. If the patient has upper eyelid drooping, also known as ptosis, which is actually spelt P-T-O-S-I-S, then that would be referral. Contact lens wearers. So an infection could be caused by the lens themselves, or could lead to a corneal abrasion. So they would need to be referred to their optometrist or their doctor. Remember, during infection, contact lenses should be removed during treatment. If a patient's had a recent eye or head injury, they should seek medical advice. And if they're photophobic, so if they have a reaction to light or pain when they're in light, they should be referred. Also, if somebody's had eye surgery or laser treatment in the last 6 months and they're having some problems, they should be referred to a doctor or optometrist. So now just a few questions just to test what you've learnt. So you've got some patients who come in with different symptoms and you're asked to recommend suitable treatment. Would you recommend a non-prescription preparation or would you advise them to go and see their GP? So a woman with itchiness on the surface of her eyes, would you recommend a treatment or refer her? A man with blurred vision, and a woman with pain within her eye. So thinking about the red flag symptoms that we've just looked at, would you recommend a treatment or refer? So hopefully you came up with these answers. Itchiness on the surface of her eyes, you could recommend an over-the-counter treatment once you've asked some more questions and you've determined what the possible cause is. A man with blurred vision, that should be an immediate referral. And also a woman with pain within her eyes, that should be an immediate referral. A worried mother comes in with her child who is 22 months old and it's suspected conjunctivitis. What questions would you ask to confirm the diagnosis? And what would you advise as the treatment? So the questions you would ask would be, is there any discharge, particularly in the morning, and are the eyelids stuck together in the morning? That can help differentiate bacterial conjunctivitis from an allergy or from viral infection. What advice would you give? You can give some of the self-care advice that was on an earlier slide. So regular bathing of the eyes to help relieve the stickiness and remove the discharge and relieve some of the discomfort. But in terms of treatment, this child is 22 months old, so it's under 2 years, and so you'd have to refer this patient. And remember, for some patients, you may be able to refer to the optometrist rather than having to always be the doctor. In some areas, you'll have a minor ailment scheme similar to pharmacies, but actually run by optometrists, and they're able to assess and provide treatment to some more minor eye conditions. So just check what's available in your area so that you know the possibilities for referrals. Okay, so that's the end of the first part of this lecture. We've covered a lot of information in this, so you'll probably need to go over this again. And remember, it's really important that you consolidate your minor ailment or responding to minor ailment learning by reading around the subject as well. So do take a look at the reading list and some of the books recommended in the reading list for over-the-counter and minor ailments, to consolidate and to get familiar with the products that are available. This is relevant to not only PAMs, sessions and consultations. You will be tested on this and assessed in OSCEs, and of course this is really important in your future career, particularly if you decide to go into community pharmacy. So anyway, take a break and then move on to the next part of this, where we'll look at ear conditions.